This echocardiographic study is of a patient with severe pulmonary hypertension. Right ventricular enlargement and dysfunction are clearly observed, prompting the question, what about left ventricular function? Although left ventricular contractility appears normal, is the left ventricular function truly normal? This pre-external short-axis view shows septal flattening, or a D-shaped septum. This severe right ventricular overload causes intraventricular septum bowing into the left ventricle, reducing its diastolic filling. Consequently, due to decreased preload and septal displacement, left ventricular stroke volume and cardiac output are reduced. The right and left ventricles are housed within the same pericardial sac, meaning that right ventricular enlargement directly impacts left ventricular function. Ventricular interdependence plays a significant role in left ventricular dysfunction in the context of severe right ventricular enlargement. And in this view, significant pericardial effusion as an ominous echo sign in patients with pulmonary hypertension is also observed. Severe right ventricular enlargement affects not only left ventricular diastolic function by reducing left ventricular filling, but also impairs left ventricular systolic function. The septal flattening or bowing towards the left ventricle can disrupt normal systolic contraction of the left ventricle, reducing its efficiency. Right ventricular enlargement often results in altered ventricular geometry, impairing in left ventricular systolic function. Left ventricular stroke volume decreases as filling is impaired, leading to lower cardiac output, and ejection fraction reduces despite preserved contractility. Chronic right ventricular dilation leads to annular dilation and severe tricuspid regurgitation, which exacerbates volume overload. In conclusion, right ventricular dysfunction is not isolated, and its dysfunction directly impairs left ventricular performance through mechanical, hemodynamic, and pressure-related interaction.